we are having n number of acute conditions which are having a higher value of HCC. Considering the time management, we are going to see about the most and higher value acute HCC value acute condition in detail in the upcoming slides. So, if you see someone clutching their chest, it doesn't always mean they forget their wallet in their home, because sometimes it is heart reminding us that it deserves attention. Yes, now we are going to talk about acute cardiac condition, the serious side of what happens when the heart decides to throw a surprise party when we didn't ask for. From chest pain to sudden rhythm changes, these are situations where quick action can truly save our lives. So let's dive in with humor in our hearts and but seriousness in our minds. We are going to explore how to recognize, manage, and respect these incredible of the heart does for every second. So first cardiovascular system acute condition is AMI. Everyone know acute myocardial infarction. It is the most critical life-threatening condition in the cardiovascular emergencies. It will be occurs when blood flow to the part of the heart muscle is getting blocked. So once the blood is getting blocked, it will leading to the tissue death. So this is the major mechanism behind the AMI. How the patient will have the signs and symptoms once they are affected by the AMI. First, they'll be having a severe chest pain that will often radiates to the arms, jaw, or back. Then they'll be having a SOB and they'll feel sweating, nausea, vomiting, and they'll be under a temporary loss of conscious and they'll feel fainting. So there'll be a sudden brief loss of consciousness due to the reduced blood flow to the brain. These are the types of AMI. So STEMI and NSTEMI are the two types of acute myocardial infarction, which is also known as heart attack, differentiated mainly by the how the coronary artery blockages happen, the degree of blockage and the ECG findings. So first we are going to see about STEMI. You can see here, right? So this ST elevation myocardial infarction is a type of acute heart attack caused by the complete blockage of coronary artery and which will leading to the severe damage to the heart muscles. It is identified by the ST segment elevation. Here, this ST part of the segment getting elevated on the ECG finding and which requires immediate reperfusion therapy. It can be angioplasty or thrombolysis, but they'll be targeted on the reperfusion therapy. And coming to the NSTEMI, this is a type of heart attack caused by the partial blockage of the coronary artery. So it will leading to the reduced blood flow and damage to the heart muscle. So unlike STEMI, it does not show ST segment elevation on the ECG. But in the NSTEMI, the cardiac biomarkers, the level of troponin will get elevated once the patient is experienced this NSTEMI. So based on the ST elevation only, we are differentiating the AMI. To be short, the STEMI is a big heart attack which need actual immediate attention. And NSTEMI is the smaller heart attack, though they will be seeking for the initial stabilization, then only they will be starting the intervention process. So now we are going to see the treatment plan, which is in terms we are telling like meet criteria for the AMI process. So they will set the patient for the initial stabilization, where if the patient is having hypoxemic state, they will be giving some aspirin to chew, or they will give, if the patient is not too much hypotensive, they will start to give a nitroglycerin, and they'll give for the morphine for pain relief, and they'll keep the patient under continuous ECG monitoring. After that, they will start the definitive therapy. So for STEMI, one second. For STEMI, they will do the process of PCI, which is preferred if it is available within the 19 minutes once the patient is getting admitted. If there is no availability of the PCI, reperfusion therapy. What is mean by immediate reperfusion? Urgent restoration of the blood flow to the heart muscle, because STEMI is caused by the complete blockage of a coronary artery, right? So the longer the heart muscle is deprived for the oxygen, the greater the damage would be. And even sometimes it will lead to the risk of death also. So emergency treatments aimed to reopen the blocked coronary artery as quickly as possible to limit the heart muscle damage and improve the survival rate. So the goal will be restore the blood flow ideally within the 90 minutes of the first medical contact of the patient. So as I said earlier, for the immediate treatment, they will be opting for the PCI, percutaneous coronary intervention, and thrombolysis. So the PCI is a angioplasty and stent placement process. They'll be performed at the 90 minutes of hospital survey, whereas thrombolysis is a clot busting drugs like antiplase or tenecteplase or streptokinase or the agents they are using for the thrombolysis purpose. So they'll be use this process when the use of PCI is not available, then only they'll be giving to the they'll be moving to the thrombolysis process. So in this percutaneous coronary intervention, they will do a minimal procedure, which is an invasive procedure to mechanically open a blocked coronary artery. So in this process, first they'll be insert the catheter. Here you can see they'll be insert the catheter usually via femoral or any kind of radial artery. Through this they'll be inserting the catheter and they'll be inflate the balloon. So the balloon gets inflated at the blockage site to restore the blood flow. After that, there will be a stent or metal mesh tube will be there. It will be placed to keep the artery open. So this is the process of PCI. So what is the advantage of this PCI process? Means it will directly remove the blockage. So there will be a low risk of reocclusion when compared to the thrombolysis process. So these are all the PCI procedure. Now we are going to see about the thrombolysis. Lysis means breakage and thrombus is the clotting which is formed in the artery. So the use of intravenous drugs which dissolves the blood clot and which is blocking the coronary artery. So the primary goal of the thrombolysis is rapid restoration of blood flow, which to minimize the heart muscle damage. The time window will be most effective if it is given within 12 hours of symptom onset. Ideally, within the first 2 to 3 hours, they will be checking for any other further damages getting for the muscle of the heart. If it is not under any additional emergency, they will be going for the PCA. So what are the common agents they will be using in the thrombolysis process? Means, as I said earlier, altiplase, tenecteplase, retiplase, and streptokinase. These are all the standard thrombolytic agents they'll be using. Now we are going to see about the coding part of the AMI. So AMI will be the main reason for admission. So it is the primary diagnosis, and we have to check difference between NSTEMI and STEMI based on the physician documentation And if the physician is given the ECG findings, from there also we can able to identify what is the type of STEMI the patient is actually having. Then we are going to see check about the involvement of the artery. So we have to check whether the wall involved or artery involved. So anterior wall or inferior wall or right or left coronary artery, which is affected by the AMI. That we have to check. And we have to check the time frame. So initial AMI will occur for the 4 weeks of onset. Suppose if the patient is experiencing new AMI, new impact within that 4 weeks of onset, it is called as the subsequent EMI. Once the patient is having that complete 4 weeks, and after that the patient experience having the AMI, means that is a new AMI. But within the 4 weeks, they are encountering or having that AMI, means it is a subsequent EMI, because the initial AMI, subsequent EMI coding selection is having a big difference in the reimbursement purposes. So we have to be cautious on picking the codes, and we have to choose the complication associated with this AMI. Either it can be cardiogenic or any other arrhythmias is having, or heart failure is the patient is experiencing. That and all we have to check, and we have to take the coding part apart appropriately. So always the coders must rely on explicit physician documentation. We should not conclude STEMI versus STEMI without clear notes. So these are all the coding examples. For anterior wall, it is I21.0, and if it is inferior wall, it is I21.1. And then if it is having any other size, it goes to I21.2. And if it is unspecified size, nothing is documented, only AMI is alone documented, we have to capture the I20.3. And if it is going as a subsequent myocardial infarction, so we have to take the I22 series. Once the patient is crossed that 4 weeks, okay, and if the patient is, and if the provider is talking about the AMI, which is crossed 4 weeks, means we have to consider it as a old MI, and we should not consider it as a acute AMI, because it is a common coding pitfall we will do in the chart process. So we have to be cautious on this in order to pick the appropriate codes. The next acute condition in the cardiac is pulmonary embolism. So pulmonary embolism is a clot which is obstructing the blood flow in the pulmonary arteries. So initially, most clots start as a DVT, deep vein thrombosis, in the legs or pelvis only. Okay, so once this clot is breaks off, they will be travel through the bloodstream and get lodges in the lungs. So this is the actual mechanism. So we know, right, what is embolism? It is a moving clot. So that is why we are naming it as a embolism. So it is starting from the legs, moving via bloodstream and clogged in the pulmonary. So it is the pulmonary embolism mechanism. What will happen if the patient is having pulmonary embolism? There will be a reduce of the oxygen supply and the strains in the heart, which will cause the sudden death if the immediate emergency treatment is not provided. So we have to see what are all the symptoms or vitals the patient will have when they are experiencing the pulmonary embolism. So there will be a sudden SOP and chest pain, and they'll be having a blood related cough will be there, and tachycardia, hypotension, syncope. So these are all the commonly experiences of clinical suspicion when the patient is encountering pulmonary embolism. The main criteria, the treatment plan for the pulmonary embolism will be, for each and every diagnosis, they will be giving the immediate stabilization. So they will be giving the oxygen therapy. If the patient is under hypoxemia level, they will giving the oxygen therapy. After that, they will be giving IV access cautiously to avoid the overload of the fluid, no, they will be giving the standardized manner. And then they'll be monitoring the patient in the hemodynamic state for the continuous measurement of cardiovascular parameters such as blood pressures or cardiac output or the level of oxygenation to access how effectively the heart and circulation are supporting for the treatment. They'll be checking. So for that, they'll be keeping the patient for the continuous hemodynamic monitoring. Once the patient is get stabilized, they will start the targeted therapy, definitive therapy. So first they will be checking for the anticoagulation because it is the cornerstone for the pulmonary embolism procedure. So they will be giving the heparin, which will prevent the clotting extension. Then after that, they'll be transition to the oral anticoagulation. So any DOACs will be there or warfarin. These are all the commonly used anticoagulants for the pulmonary embolism. And then they'll be going for the thrombolysis process because additionally with the pulmonary embolism, if the patient is experiencing shock, they'll be going for the thrombolysis process where there'll be IV fibrinolytics like altiplase, tenecteplase will be given to dissolve the clot, and it can be used only if patient is unstable during the bleeding risk. So for higher severe cases only, they'll be opting for these procedure and all. Even if the patient is not responding for the thrombolysis purpose, thrombolysis procedure, they will going for the surgical procedure like catheterization based interventions of ectomy, embolectomy, like complete removal of the clot, or catheter directed thrombectomy. That surgical procedure and all, they'll be given once the patient is not responding to this minimal procedure, they'll go for that. And after that, they'll be giving supportive care also. If the patient is continuous shock, they'll keep the patient in the vasopressors. And if the patient is having any respiratory failure because of this pulmonary embolism, they'll give mechanical ventilation support also. So these are all the treatment criteria we will be checking for the pulmonary embolism. Now we are going to see about the ICD coding part. So as I said earlier, we have to cautious on the primary diagnosis, specificities, and what are the associated conditions there, because each and every code is having its own reimbursement value. So we have to keep an eye on while coding the conditions. So pulmonary embolism is coded as the first principal diagnosis if it is the main reason for the admission. Always we have to check whether the patient is having acute cor pulmonale, which is also known as right heart failure, right heart strain, because it plays the specificity. With or without acute cor pulmonale, we have to capture. What is acute cor pulmonale? It is the enlargement and failure of the right ventricle because of this pulmonary hypertension. What will happen means the right ventricle cannot pump blood effectively against the sudden rise in the pulmonary artery pressure, which will lead to the systemic hypotension, shock, and poor oxygen delivery also. So what is the difference between the chronic cor pulmonale and acute coronary pulmonale means? Chronic develops slowly. So if the patient is having COPD or any pulmonary fibrosis means they will be having a chronic cor pulmonale. But in the acute state, acute cor pulmonale, they will be having a sudden life-threatening serious conditions will be there. So we have to choose the correct specificity, because if the patient is having only the chronic cor pulmonale, but we are capturing pulmonary embolism with acute cor pulmonale, it will leading you to the error path. So we have to be cautious on while selecting the condition. After that, if their patient is having any other secondary associated diagnosis like with DVT, shock, any respiratory failure, that also we have to capture. And the primary criteria, documentation. coders always rely on explicit physician documentation because we should not assume the type of the pulmonary embolism or complication on our own. So this is the coding criteria. I-26.0 is captured as a with acute cor pulmonale, and if there is no evidence of cor pulmonale, we will be capturing I-26.9. If the patient is having chronic pulmonary embolism, explicitly it has to be stated as chronic. Then only we have to capture I-27.82. And if the provider is describing this embolism is related to any other previous surgery or any other procedure, no, that time we have to capture the T series code, which is post procedural pulmonary embolism. And this is the another acute condition in the cardiac system, which is cardiac arrest. So what does mean by cardiac arrest? Arrest means cessation. So sudden cessation of effective heart activity where the heart stops to pump the blood due to the electric malfunction, so which lead to collapse or unconsciousness within the second. So what is the difference between heart attack, which we have seen before AMI, and this cardiac arrest? Now we are saying cardiac arrest is the electrical problem where heart stops beating, whereas the heart attack is the circulation problem. So there will be a blocked coronary artery which reduces the blood flow. So both in cardiac arrest and heart attack, the fatality risk will be high because if it is not treated within the minutes, this cardiac arrest, the patient death rate will be very high. So based on these, there will be a three classic rhythms in the cardiac arrest. First one is ventricular fibrillation. It is the most dangerous heart rhythm disorder where the ventricles actually quiver instead of pumping the blood. So it is a chaotic and irregular electrical activity in the ventricles, causing them to twitch. Instead of contracting, they will start to twitch the pulses. So what will happen when the patient is having this ventricular fibrillation means the blood circulation will get stops. Once the circulation stops, the patient will get collapse, unconsciousness, and even leads to death also. So this ventricular fibrillation is the most common cause for the sudden cardiac arrest. So it is the medical emergency which requires immediate CPR or any defibrillation assistance. So CPR is the cardiopulmonary resuscitation process. Is a life-saving emergency technique. It is used someone's heart or breathing has stopped, such as during the sudden cardiac arrest. The key is to push hard and fast in the center of the chest at 100 to 120 compressions per minute, which will be rescue the breath if it is safe. Okay, so this is the process of CPR. Then we are going to see about the pulseless ventricular tachycardia. It is also a life-threatening arrhythmia where ventricles beat so fast. So tachycardia means higher rate, the fast manner of the cardiac heartbeat. So the ventricles get beat so fast and they cannot pump blood, resulting no pulse and sudden cardiac arrest will be there. So usually the rapid ventricular rhythm will be over higher than 180 beats per minute within the wide QRS complexes in the ECG finding, but there will not be a effective cardiac output. The heartbeat will be high, but that will not give a good output of the blood heart pumping. So that is the base for this pulseless ventricular tachycardia. What is the difference between the pulseless ventricular tachycardia and normal ventricular tachycardia means usually this ventricular tachycardia has sometimes a pulse, But this PVT means the rhythm is present, but we cannot detect that pulses in the ECG findings. Then coming to the asystole. What is asystole? What does mean by A in the medical terminology means absence. So this asystole means the rhythm where the heart has no electrical activity at all. Actually, the providers will feel easy to find out this A systole in the ECG findings because they cannot able to see any lines and all, any up and down lines and all. So there will be a complete flat line. So which leading to the immediate loss of conscious and death within the minutes if it is not treated by the CPR or any other emergency care. So it is not a shockable rhythm, meaning defibrillation does not work. Only rapid CPR or any other epinephrine or any treatment of underlying causes of this asystole only will help. So to be precise, it is the complete absence of heart electrical activity. There will be no heartbeat, no pulse, and no blood flow. So in the ECG appearance, you can see, right, flat line will be there and outcome will be immediate intervention will be has to be provided. Otherwise, death occurs within the minute. Then we are going to see about the aortic dissection. So, which is a rare but deadly emergency where the inner layer of the aorta, no, it is a broad artery in our cardiac system. So, this inner layer of the aorta get tears and causing the blood to split the vessel wall. So, it often presents with sudden severe chest pain, which is known as a ripping or tearing. So immediate diagnosis and treatment has to be provided. Usually they will going for the surgery only. So to be precise, it is a tear in the inner layer of the aorta, which is allowing blood to flow between the layers of the vessel's wall. So there will be two types of aortic dissection. Type A involves the ascending aorta, which is placed near the heart, which requires emergency open heart surgery. And the type B will be involved in the descending aorta. It can be managed with the medications or any minimally invasive stent repair. Unless the complication is arises, they'll go for the surgery process. Then coming to the aortic aneurysm. So a ruptured aortic aneurysm is a medical emergency where the wall of the aorta is getting weakened and there will be a burst. You can see, right? So there will be a burst of the aorta and causing massive internal bleeding. So survival depends on the immediate recognition and urgent surgery should be provided. But even with the treatment, there will be a low chances of survival only in when the patient is encountering the ruptured aortic aneurysm. And we are having two types of aneurysm: abdominal aortic aneurysm, which is common and it is occurs in the belly, and thoracic aortic aneurysm, which is occurs in the chest. And then there will be a emergency surgery is required. So they'll be doing two types of repair. One is open repair and another one is endovascular repair. So what does mean by open repair means? So they'll be replace the ruptured section completely with a graft. Whereas in the endovascular repair, they'll be using minimal invasive stent graft. Via the catheter, they'll place the stent. So compared to the endovascular repair, open repair will mainly focus on the complete removal of the affected aorta part. Okay, so it can be considered as a complete cure, whereas endovascular repair is the support only. So apart from that, they'll be giving a supportive care of IV fluids, or they'll be going for any blood transfusion or any oxygen support in order to control the blood pressure. So these are all the key differences between the aortic dissection and ruptured aortic aneurysm. So what is the major cause means? In the aortic dissection, there be a tear in the inner wall of the aorta, whereas in the aneurysm, it will get weakened and start to burst itself. And onset here, they will be having a uh, sudden and immediate chest pain will be there. But here there will be along with the chest pain, there will be the patient will go for a shock also. And risk factors, if the patient is having hypertension or any other trauma or connective tissue disorder, they'll be having a higher probability of getting aortic dissection. Whereas if the patient age and male patient and smoking and hypertension, and if the family history, these are all the major causes and risk factors for the ruptured aortic aneurysm. And how they will be diagnosis this aortic dissection means they will use this CT angiography or echocardiography, whereas this ruptured aortic aneurysm can be seen using the ultrasound or emergency imaging procedures. If they are having, they'll be able to identify this aortic aneurysm. Because of the internal bleeding, it cannot be able to visualize using the CT angiography. So they'll be using any other extra facilities for the imaging purposes. In the emergency care, they'll be using for the ruptured aortic aneurysm. And coming to the treatment purpose, so aortic dissection will be having a type A, which is having a very higher survival rate. They'll go for the surgery. Whereas type B, due to its low acute nature, they will start to treat the condition using medication. If it is not supporting, they'll go for the surgery. Whereas in the ruptured aortic aneurysm, they'll go for the open or endovascular repair based on the level of the severity the patient is experiencing. And coming to the survival rate, if it is untreated, the patient will get the death rate of the patient will be high. But in the ruptured aortic aneurysm, it is very high. Even if the provider is giving the particular treatment, immediate surgery, they will be having a higher death rate. Have you ever wondered why doctors look so serious when they talk about the lung cleanup? It is not because someone forget to sweep the hospital corridors. It is because the lungs, our body's ultimate air filters. And when they get clogged or stressed, things can turn critical very quickly. Yes, you have guessed it right. Now we are going to focus on the respiratory system and its acute condition. So, from shortness of breath to sudden emergencies, this system reminds us that every breath truly counts. So, let's inhale knowledge and exhale curiosity. Let's dive into the fascinating world of respiratory health without running out of breath along the way.